We'll go ahead and get started. First of all, thank you all for joining us this evening for the webinar titled The Role of Pharmacists Supporting Patients in Recovery. To kick things off, I want to thank our sponsor, Walmart, who does sponsor Operation Substance Use Disorders and this opportunity this evening. And next, it is my pleasure and honor to introduce you to our guest speaker, Dr. Haley Powles. Dr. Powles graduated from Drake University's Doctor of Pharmacy program in 2018, and then completed a PGY-1 Ambulatory Care residency with the University of Minnesota and then did a Psychiatric PGY-2 residency at the William S. Middleton Memorial Veterans Hospital in Madison, Wisconsin. In 2020, Dr. Powles then joined the Toma VA as a clinical pharmacist practitioner specializing in substance use disorders. She performs comprehensive medication management for the outpatient substance use disorder clinic and works collaboratively with the ex-waivered psychiatrist to provide buprenorphine treatment. So please join me in welcoming Dr. Haley Powles.
Thank you, Maddie. And I do not have access to the chat, but you guys are welcome to ask questions throughout as I talk. And I'm relying on Maddie to relay those to me, or we can just wait till the end. I also want to apologize. You can see I'm at my home office and my cat really wants to join us. So I really apologize if you hear him trying to join us this entire time. But let's get started. I want to kind of do a little bit more introduction and background because I'm really glad that you guys are all here for this talk and getting to listen to what our pharmacists are doing these days for our patients. As I was a student kind of in your seat, I dreamt of this job and I really wanted to do this, but I had no idea it existed. So I was really grateful for all of the opportunities and experiences that I had as a student that kind of introduced me to what I'm doing now and making it possible to do what I'm doing. So things like APHA's Institute on Addictions, I attended that when I was a pre-pharmacy student, not even a P1 yet. As a first year freshman in college, I was really interested in this already. So I was actually invited to be joined our Iowa Pharmacist Recovery Network meeting just to kind of get a taste. So I kind of always had an interest, and I'm really happy that you guys are here getting an interest as well and getting to kind of see what my journey looked like. And hopefully if you're interested, you can kind of follow your own journey in this. So that being said, I'm going to start with my typical disclosure that nothing I say here today is representative of the VA or their thought processes. This is all my own opinions, kind of our standard disclosure. And then as far as our objectives for what I want to talk with you guys about tonight, just kind of getting a sense for what recovery means for our patients and kind of following through their journey and seeing where pharmacists can kind of step into that journey and help them out. And specifically how we can do so with some careful language so that we can start practicing right away before you become a pharmacist. As always, we're going to start with the definitions of, what is addiction? What is a substance use disorder? Kind of your classic definition, of course, being, overusing, building tolerance to a substance, having withdrawal symptoms without using, things like craving that substance. And certainly this might sound like every pharmacy student's relationship with caffeine. If we don't have it, we get caffeine headaches. We use more and more of it to help us study because it's not doing enough. But certainly there's some other things that makes a substance use disorder an addiction, or, not just a caffeine habit or something like that. So think about things like using in hazardous situations, such as drinking and driving, or using when it's hazardous to our health, whether that be physical health or mental health. And continuing to use despite problems with our relationships, with our work, just basically with our society or with our functional capacity in society. Once substance use starts to interfere with that kind of stuff, it becomes a substance use disorder, becomes a problem that we really have to tackle. One hypothesis for why this happens or how this works kind of relates to the reward pathway. I'm sure you guys have all heard of this pathway in our brain. It's kind of tucked in next to our memory center and our behavior center. And all it does is release dopamine. And dopamine is kind of our happy chemical. So what that does is rewards us when we do a behavior that our brain thinks is good for the species. So if you think about being an animal, things that are good for the species is making sure you're hydrated, you're eating food, and you're procreating. So all of those things naturally bring us a reward because it's what we have to do to survive. Now, if you think about something exogenous or artificial kind of activating this pathway, it can definitely ramp up that dopamine in the same way, but it does so more so. So this isn't, a little bit of dopamine from your favorite cheeseburger. This is a lot of dopamine from, methamphetamine, alcohol, what have you, and constantly, aggressively attacking this reward pathway tends to lead to damage. Then it can't really work as properly as it should. And that's kind of how we get stuck in this cycle of overusing substances or becoming dependent on them. So being the nerd that I am, I wanted to show a picture to kind of represent this in the brain. If we're actually looking at dopamine cells in our brain, on the left here, this kind of weather map looking thing is a brain from the top down view. Those nice little shapes are our reward pathway. And as you get into the weather map, the dark red is really concentrated dopamine receptors, and a nice shape along the reward pathway where our dopamine receptors are working properly, they're in excess, and they're doing their job. And then on the right side, this brain is someone who has used a lot of methamphetamines. And again, excessive activation of those dopamine pathways tends to lead to damage. So after a lot of methamphetamine use, you can tell that those shapes really aren't very formed anymore. There's not a straight delineation of where that reward pathway exists. And there's not as much concentration of those dopamine receptors. So we can actually see this on brain scans that our dopamine receptors and that reward pathway is just not working the way it should in patients with addiction. And so over time, if we think about kind of the lifeline of a substance use disorder, or any substance use, of course, someone starts first never having used a substance or being abstinent, being acutely intoxicated. After that, they go into withdrawal or have, kind of after effects of that, cravings for it. And then we kind of in a period called early recovery where they're kind of getting not quite in remission yet, but they're not, no longer using or actively using. And unfortunately, this pathway tends to kind of get stuck here, where patients are at the highest risk for relapse in their early recovery. So unfortunately, it might take people a few times of going through this cycle of intoxication, withdrawal, and attempting to find early recovery or remission before it really sticks. So unfortunately, our pathway is not always linear before they get to remission. So we're going to go through each step of this pathway and kind of talk about what care looks like, or what what interventions anyone can be making at any certain point in time. And then we'll go back through it and kind of figure out where pharmacists can play in it and talk about what we can be doing. So before anyone uses substances, think about your, grade school DARE education class, if they still have those. These are public education awareness, teaching people about safe consumption, safe alcohol limits, just overall education about substances and their use, tobacco commercials, those classic weed commercials, and the PSAs, those kind of things that anyone can be providing to the general public. And then there's also stigma reduction efforts. So talking about mental health, talking about addiction, using specific language about it so that if people do have problems, they feel comfortable coming forward and seeking care for it, or maybe even, addressing it before it becomes a problem. And then, of course, harm reduction strategies. And so those are things that we are actively doing to make it safe for people who do choose to use. So you think about sterile syringes that we can provide, naloxone, making sure they have an opioid overdose reversal on hand in case they do use too much, and then fentanyl test strips in case their supply, opioid or not, is tainted with fentanyl. They are aware of it and can maybe avoid use or be a little more cautious about their use. And when we think about language and kind of the stigma piece of it and how we can talk about these patients or people in general, here are just some examples. So of course, person first language with everything that we do as pharmacists. But for alcohol use disorder, we don't use alcoholic or drunk. They are a person with alcohol use disorder. We don't call people addicts or junkies. They are a person with a substance use disorder. And then even the way we talk about their lab values. So their urine drug screen is not clean or dirty. their urine drug screen is positive for methamphetamines or negative for opioids, or what have you. And then once someone is using, while they're actually intoxicated, there's not much that we can do in that moment. They're already intoxicated. Usually this means that they are not in the right state of mind to really be discussing treatment or what the next steps are. So our primary goal is just safety. Make sure that they're in a safe environment. They're not drinking and driving like we talked about earlier. We're making sure that that substance use isn't leading to toxicity or overdose, that we're keeping an eye on that. And we can provide some education at this point, mostly just, safety measures again. They're not here to, it's not quite time to tell them, the whole menu array of treatment options that we have available to them. We're mostly just trying to get them through that intoxication into a safer spot. So after that, once they're not intoxicated anymore, they're probably going to be feeling pretty crappy and feeling in withdrawal, depending on the substance. So again, we're just there to kind of support them, make sure they get through withdrawal safely. If there's any specific symptoms that we can accommodate and help with, we can provide them some therapies for that. And then some substances, for example, alcohol, that withdrawal actually can be deadly. So there are some supportive measures that we can take in order to prevent them from having seizures, for example, or prevent them from having delirium tremens or hallucinations that can be very severe with alcohol withdrawal. Essentially just making sure that they are comfortable and safe so that they don't have a fatal withdrawal symptoms. And then once they are kind of past that acute withdrawal period, looking into early recovery. Again, this is that highest risk for relapse, that kind of key point where they've got a lot of touch points within the healthcare system. They are constantly getting seen just to maintain that progress and continue to stay sober. Some of those withdrawal symptoms can kind of linger for a little while, so not just those acute withdrawal symptoms, but maybe some fatigue or depression that we could be helping them with to kind of help them through that. Relapse prevention medications, which we'll kind of touch on in a little bit, but of course that's our specialty as pharmacists. We tend to know a lot about the medication piece of it. Any comorbidities they might have that might be contributing to their substance use, we definitely want to start treating these at that time. We do not want to wait until the addiction is under control before we start, addressing their PTSD or their depression. We can treat those things at the same time, because realistically, if we're treating their PTSD or depression or whatever it is that's making them use substances, we can decrease their risk for relapsing and using substances again. And of course, there's a lot of different therapies that can also be provided at this time to help them that we'll talk about in a moment. So getting to our wheelhouse, the medications, there's a couple different types of targets, and it kind of depends on the substance. Some substances, the targets just work a little bit differently, or we have better medications that actually work for those substances. So for example, medications that target cravings for things like tobacco and opioids, we use a lot of agonists. So we actually use nicotine replacement products like patches, lozenges, gum, those kind of products that stimulate the nicotine receptor so that people don't have cravings for it or cravings for that cigarette. Same thing with opioids, methadone being a full agonist of an opioid, and then buprenorphine or Suboxone being a partial agonist of the opioid receptors. Those can kind of, alleviate some of that craving just by actually acting on that receptor, but definitely nowhere near as activating or as dramatic a response as heroin would be. We're giving them a prescribed medication in a controlled environment at a steady dose that's safe for them. So that's helping with their cravings. But then for alcohol, it works a little bit different, that the anti-craving meds, they don't act like alcohol. They're not, attacking those receptors in the same way that tobacco and opioid medications do. But our naltrexone, our camprosate, and our gabapentin help kind of alleviate those cravings. Or if someone does continue to drink, kind of takes away that pleasure of the alcohol use. Some of my patients have even said it makes the alcohol taste different. It just doesn't taste as rewarding. So kind of a little bit different target, but essentially if we can help these patients not crave the substance physiologically or mentally, then they're going to be less likely to relapse and use. So that is kind of the primary target for our medications. We can also kind of use a receptor blocker. So things like our antagonist or naltrexone opioid antagonist kind of just sits on those receptors and waits and prevents that if someone does relapse to opioid use, they're kind of protected where those opioids won't get into those receptors because that naltrexone is kind of sitting there and protecting against that. Doesn't provide quite as much craving relief. So sometimes it can be not an ideal choice for some patients, but it's a good option. And then kind of the last medication target that we don't really use anymore is those deterrents. So disulfiram or antabuse is kind of the classic medication where if someone drinks when they're taking it, they're going to get sick. And it's kind of like a punishment for relapsing. So it's why we don't use it so much anymore. It definitely has its place, and I definitely prescribe it from time to time. But that punishment piece really isn't how we should be treating a mental illness or a medical illness like substance use disorder. So we don't see it used quite as often. Essentially what's happening is it's not allowing your body to break down that alcohol properly. So this toxic byproduct kind of gets stuck in the middle and builds up. You can get nausea, you can get vomiting, you start to flush and sweat. And it's a really uncomfortable reaction. So uncomfortable that if it gets really severe or if someone continues to drink, and we can have some cardiac issues. So we do have to be careful about what kind of patients we give that to, just to make sure that if they are at risk for relapse and they're going to drink on it anyway, and we're not, putting them at risk for cardiac side effects, or if they already have underlying cardiac issues, we're not putting them into more danger. And I didn't really touch on varenicline or bupropion for tobacco, but they're kind of other sneaky anti-craving medications that we're not really sure exactly how they work, but they decrease the patient's kind of desire to smoke a little bit differently than the nicotine replacement products do. And then, of course, our therapies. So this is what our colleagues that we will not be providing these therapies, or most of them, I'll get to that. But our colleagues are in charge of, kind of providing some of these therapies for patients while they're in recovery, kind of seen as the gold standard. Medications are not always the first line therapy for these patients, but these cognitive therapies or these group-based therapies really are ideal. So cognitive behavioral therapy kind of being the gold standard for any mental illness, just changing the way that we're thinking about certain things, allows us to kind of work through those cravings as we have them in the moment, and allows those patients to restructure their thinking about it and get through that. Contingency management is a very specific type of therapy, or a group therapy basically. And it's working primarily for methamphetamine, cocaine, or stimulants. It works the best for that. We can see it used for marijuana or opioids, not as much alcohol, but it's got the best evidence for those stimulants. Essentially what's happening is they are providing a urine sample, and if it is negative for their target substance, they get a prize basically. So their prize is contingent upon a drug screen that comes back negative for their substance. Within the VA system, it's really easy because we have a VA canteen that we can provide them coupons for. So as they continue to get more and more progressive urine samples that are negative for their substance, they pick more and more little draws out of a fishbowl. And some of those draws might just say, good job or congrats. But some of those draws might say $1 or $5. Or we even have one jumbo one hidden in the fishbowl that's like $100 for the canteen. And if you've ever been to one of the VA canteens, there's like TVs in there. It's not just like snacks and coffee and, a fridge at the back. It's actual good things that people can look forward to. So for some reason, we found that incentive or that kind of benefit or reward plan to keep them from using has actually been really helpful. And again, specifically in stimulant use disorder, but we also use it for our patients taking the naltrexone injection. Every month that they actually get their injection on time, they get more and more draws. So it's got a couple of different uses that we can find for. Group therapies, that covers a very, very wide range of what that could look like. But essentially, we're taking some of those recovery-based therapies and putting it in a group setting so that people can kind of work off of each other's lived experiences and help each other out in need. because a lot of times, as providers, we have a lot of expertise and understanding of this, but they want to hear it from someone who's been there before and who's done this before. And hey, this worked well for me. It might not work well for you, but try this. And so that's the benefit that we get from group therapies. And that can look like a lot of different things depending on who's running it. 12-step programs are probably your most classic example of AA, NA, whatever works for that patient. Sometimes there's a little bit of turnoff for the religious based to some of those programs. So there's some that are, Soberize or, other programs that aren't so faith-based or AA, just because they aren't everyone's flavor. So there's multiple different avenues that people can go to, basically on the premise of anonymity and being in the community. So providers usually not monitoring those. It's just within the recovery community. And then lastly, I threw medication education on there. Of course, being a pharmacist, we can run med education groups, make sure that they're aware of what medications are available to them, questions that they might have, other things outside of substance use, but their diabetes meds, their other things. We can provide a kind of group like that to allow them a forum to ask these kind of questions. Finally, last step on this kind of recovery pathway is remission. So once we do all of those therapies and it works and they stay abstinent from their substance, then we get to a point where they kind of join those treatments as needed. If some of those treatments were really helpful or they enjoyed them, they can stay in those treatments. Usually the medications kind of come off by month 6 to 12, depending on the substance and the confidence of the patient. Those don't need to be there lifelong. Sometimes medications like Suboxone or methadone can be more indefinite if they're not ready to come off of them or if they've built up quite a dependence to opioids. But for the most part, once people get to remission, it's just kind of as needed support. They don't need to join group every month or every week. They don't need to be on medications. So at this point, we're kind of just encouraging them to stay sober, to remember their resources if they need them, if cravings return again, and make sure that they've got an updated naloxone or Narcan kit. Because of course, after being in recovery and not using, if they were to relapse, their tolerance is gone by now. So if they were to relapse, we want to make sure that they're safe because they're at a very high risk for overdose, overdoing it, and passing away if they use after some recovery time. So now we are going to circle back to all of these points that we've talked about and kind of talk about where pharmacists can touch at this point. So in the beginning, when we talked about abstinence and kind of some of that, those harm reduction materials, in most states, sterile syringes and naloxone is now on standing order where we can provide those to patients without a prescription or without a physician's order. I learned that when I was working at a retail pharmacy in pharmacy school that I definitely recognize that not all of my colleagues or coworkers or pharmacists were comfortable dispensing some of those things. So I kind of became the go-to person that, hey, Haley, so-and-so's at the counter, would you mind caring for them? And that's how I was known. And I was okay with that because that meant that our patients knew someone was there that would be willing to do that for them and help them out. So as much as you can make that known that you're comfortable doing that, and that means that those patients are going to get those materials. So those are available at pharmacies, and that's something that every pharmacist can do. Or if you work in a VA like I do, I have prescriptive authority or scope of practice where I can prescribe those if I need to. I can prescribe an naloxone kit. Wisconsin just recently legalized fentanyl test strips, so we're working on getting those available as well. But that's something that all pharmacists can do. All pharmacists can educate our patients, and this is any step of the point or any step of the way, whether they're using or not, and we can be educating our patients on safe consumption. That can be counseling them that their zolpidem shouldn't be taken with alcohol. That could be counseling that their alcohol use could be affecting their blood pressure. Anything that affects their health, not just addiction, but just counseling them on the use of substances in general. All of us can be doing that. And then, of course, that destigmatizing language that we talked about, not just in front of our patients, but in front of our colleagues and other pharmacists, even at home, in front of our family and friends. And we can all be using that destigmatizing language. Once they're intoxicated, again, like I said, there's not a whole lot we're going to do at this point, except just make sure that they are safe and taking it easy. In the hospital setting, that could mean that we're helping providers or hospitalists select medications that are safe for them. So for example, if there's a home medication like bupropion that could reduce the seizure threshold, we're making sure that that provider is not going to continue it while they're at risk for seizures from withdrawal while they're here in the hospital. This could be, again, counseling a patient on which medications they shouldn't drink with or shouldn't be using other substances at the same time as. So that's something that we can do in the inpatient or outpatient setting. After being intoxicated, once they're in withdrawal, again, in that hospital setting, we can really be helping with those withdrawal protocols. So helping with those protocols that are set up for alcohol withdrawal to make sure that we are judiciously using benzodiazepines to make sure they are safe and protected against seizure and other complications, but that we're not over prescribing benzodiazepines or causing unnecessary lengths of stay in the hospital and side effects from that. So making sure we're doing that safely, pharmacists definitely can have a play in those protocols. We're even starting to see some outpatient withdrawal protocols, or for example, when I'm starting someone on Suboxone, I can give them some clonidine to help with their opioid withdrawal. So we can do that in the outpatient setting as well. Then early recovery, where I said a bulk of this work is being done. We can do those medication education groups. We can dispense nicotine products. Those are over the counter. It doesn't have to be from the pharmacy, but we can certainly counsel patients on it or educate them on it. In most states, pharmacists can do, I guess I don't know exactly, but some states, pharmacists can do injections. So we can be giving naltrexone injections at our clinic or at a pharmacy. That is something that we have within our scope to do. Or comprehensive medication management. If we're in a facility or we are part of a collaborative practice agreement that allows that, or recommendations, not just prescriptive authority, but we can participate in that part of the process too, that we can be suggesting these medications for substance use disorder or prescribing them ourselves. And then lastly, once a patient gets to remission, we can help support them and encourage them and say, congrats, that's awesome. You must be so proud of yourself. Continue to encourage them to seek that care and stay up with it. And just provide them a safe, inclusive environment that they feel supported in their recovery and that they feel comfortable talking about it. Especially if they were to relapse, they feel comfortable coming to us as providers and talking about that. And at any point, we can always educate our colleagues on these therapies that are available, whether that be for intoxication, withdrawal, or cravings and like relapse prevention medications. We can always be educating our colleagues on that. So we are going to spend a day in my clinic. In our clinic at the Toma VA, we have prescriptive authority as pharmacists, clinical pharmacists, at least in the various clinics. So we are going to see one patient kind of come through our healthcare system and see how he interacts with all the pharmacists at our VA. So our patient today, MK, shows up to his primary care appointment. This is his annual visit, and he tells his provider, I'm really afraid to shut my eyes because I know I will have the flashbacks. So clearly dealing with some PTSD that's not well treated at this time. He also has opioid use disorder history and diabetes that is insulin dependent and high blood pressure. His blood sugars are not looking good. They're pretty elevated. His liver enzymes there are also elevated, but everything else looks within normal limits. On exam, the provider notices that he's pretty frail and lost quite a bit of weight. His right knuckles are pretty red and warm to the touch, and it's visible that he's got some puncture marks in his knuckles there from injecting. So the PCP decides that he needs to go see the pharmacist for some more hands-on diabetes care to get his diabetes under control and get his blood sugars better managed. So pharmacist number 1 sees veteran at his diabetes visit, and the pharmacist notes that he really hasn't been able to use his insulin because he's using all of his syringes for heroin administration. So he hasn't been able to use his insulin, and he's too ashamed to ask for more syringes in order to use his medications properly. So we are going to pull up a poll and get your guys' opinion on what we should do for this veteran. What can this pharmacist do? Should we offer naloxone? Should we provide some more sterile syringes for him? Should we educate the veteran on the harms of opioid use disorder? Or should we prescribe buprenorphine? And this is not a therapeutics exam, There may be multiple answers, but you can only pick one. Just pick whatever sounds best to you. We do not need to worry about what's actually correct because there might be a couple of right answers. Real world is a nice gray area. And then Maddie, I am going to leave it to you since I cannot see the poll. Whenever it looks like there's a slowdown in people responding, we can close that out and see the results. Looked like most people said provide more sterile syringes. A few said educate them or offer naloxone, and you guys are absolutely right. The only thing on this list that we cannot do as pharmacists is prescribe buprenorphine. That is something that the DEA requires an X waiver for, so a very specific licensing, and pharmacists are not yet on the list of eligible X waivered prescribers. So we cannot prescribe buprenorphine. Of course, we can collaborate with our psychiatrists who do, and we'll get to see that how that works in a little bit. But we can do A, B, or C. We could offer naloxone to him, make sure he's got it. We can provide more sterile syringes. I like that was the most picked answer. You guys are definitely in therapeutics mode because that is what his complaint is, that he can't control his diabetes because he doesn't have enough syringes. And of course, we can always educate the veteran on what opioid use disorder could be doing to him and what those injection practices could be doing to him as well. And that doesn't require a scope of practice. None of the things that I just said we could do for this patient requires a scope of practice. If you are, counseling this veteran at your outpatient pharmacy and you've got naloxone on standing order, you've got syringes that can be given over the counter, and education is always free, of course. So those are things that you don't have to have a scope of practice like this primary care pharmacist does to be able to do those things. So the primary care pharmacist decides it's really hard to manage diabetes while his addiction is active. So they're going to kind of put that on hold. He's not using his current regimen as prescribed anyway. So kind of working on maybe some of that addiction piece of it and then improving his adherence to his existing regimen might show some benefit first. So they're not going to make any changes to his diabetes today. Instead, she asks the veteran a little bit more about their heroin use in a non-judgmental way and educates him on the health effects of his opioid use disorder. She does provide naloxone, some more sterile syringes, and lets him know that those are available without prescription for his insulin, but more sterile syringes are available to him without prescription for safe injection, and then provides him with some fentanyl test strips and educates him on why that might be important for him with his heroin. And then she refers him to the substance use disorder clinic to be seen for further evaluation and decides that they need to walk down to urgent care right now to get his hand looked at because his hand looks like it could be infected. So in the urgent care, when they get there, the urgent care provider cultures his wounds, and at lightning speed, they come back that it's positive for MRSA, and they get the culture and susceptibility report immediately because we are magical at this hospital. And then the urgent care provider cleaned and dressed the patient's wound, so it's looking healthy. The ID pharmacist on staff recommended an appropriate antibiotic to the provider based on the culture and susceptibility. And then he noticed that because of the IV drug use and the elevated liver enzymes, the patient hasn't had a Hep C panel in a while, so he gets an updated Hep C panel just to make sure that the veteran isn't actively infected. And then the patient or the pharmacist, the ID pharmacist here in urgent care, counsels the veteran on the antibiotic he's going to go home on from the urgent care provider, and then reminds him about some safe injection practices. So at that point, he goes home on an antibiotic and shows up to my clinic in the substance use disorder clinic the following day. He tells me a little bit more that he's using about a 0.5 gram of heroin IV every day for the past 6 months. And his chief reasoning or complaint is that it's to get rid of the images. So again, going back to that self-medication aspect of PTSD, that's why he's using substances. So we kind of talked a little bit more about what he's been doing for his PTSD. He has been through a residential treatment program, but it was 15 years ago, and he hasn't really done anything for it since. His last heroin use was yesterday around noon, so it's been about 36 hours by now. He's feeling some withdrawal symptoms. He's definitely pretty nauseous. He's kind of sweaty, and had diarrhea before he came to this appointment. So what's the best treatment for him at this point? We don't have a poll for this one. It's a very open answer. There's a lot that we could do for this patient. Again, I can't prescribe Suboxone myself or buprenorphine, but we can do a lot of the other things that we talked about as far as education, other medications. I do have a scope of practice to treat those comorbidities at play in that PTSD. We've got group therapies at our disposal. So after providing some of these options to the veteran and kind of talking about what he would be interested in, I educated him on all of the medication options. So methadone is not available at the VA, but we could get him a referral to a local methadone program since they do have to be licensed for that and we are not. Naltrexone wouldn't be the best option just because of his liver function, especially if his Hep C panel does come back positive. Really, Suboxone is the only medication that we could offer him here today. And he does think that that would be a really good idea. And since he's already in withdrawal, it's something that we can go ahead and get started right away. So we are going to work collaboratively with our ex-waived provider for them to then see this veteran immediately after us, kind of confirm our assessment and that Suboxone would be appropriate. And then they will go ahead and prescribe it and we'll continue to manage it moving forward collaboratively with them. Under my scope of practice, I am able to prescribe an antidepressant, which is first line for his PTSD. So we went ahead and chose sertraline 50 milligrams because he had been on it before and found benefit in the past. I referred him to individual psychotherapy and he wanted to join a recovery support group. So nothing too formal, but just a support group once a week. And we hold those virtually thanks to COVID. And we've been doing those virtually and he was really happy about not having to go out and do those. So fast forward 2 months, veteran shows up to the outpatient pharmacy to pick up all of his prescriptions. He is still on 50 milligrams of sertraline. He worked his way up to 8 milligrams of buprenorphine or Suboxone, and he gets to pick up his last 4 weeks of Harvoni because he was positive for hepatitis C. The outpatient pharmacist asks him how he's doing, asks him how his medications are, and he finds out that they're going really, really well, and he's celebrating 1 month of sobriety today. So the pharmacist offers if he needs more sterile syringes or a new naloxone kit at this time, and he proudly shares that he does not because of that sober time. The pharmacist commends the veteran on his 1 month abstinence date and congratulates him on that, and then reminds him that when he's done with that 4 week supply of Harvoni, he needs to call the ID pharmacist again. So as we went through that journey of our patient, we found that we stopped at 4 different pharmacists along the way. 2 of them had scopes of practice or actually one of them only had a scope of practice that could prescribe medications that were necessary for him. The ID pharmacist, of course, had ability to order labs and order that hepatitis C panel. The PACT pharmacist didn't need that, and the outpatient pharmacist didn't need that. They were able to provide meaningful encounters with this veteran to help him in his care. And that being said, this is the kind of end of my veteran journey and my guidance through that. But I want to remind you kind of back to what I said at the very beginning. My first touch point in this field as a new practitioner, pre-professional student, was at the Iowa Pharmacy Recovery Network, where that care is specifically because pharmacists are also in recovery, and our colleagues, our physicians, our pharmacists, we're at a higher risk for addiction than other people in the general public, just because of the job that we do, the wealth of knowledge that we have, the stress that we're under. So it's not just these patients that we are going to be seeing and can make a difference. That anti or destigmatizing language does not stop when that patient leaves the room. It's also in front of your colleagues, it's in front of your family and friends, because you never know who's in recovery around you. And making sure that everyone feels comfortable to talk about this and open up to you is really important as a professional. So that is my last pitch, that this isn't just about patients, but all of us as well, so that you guys can feel comfortable if this ever is an issue for yourself or your close colleagues, you feel comfortable discussing it with them. And with that, I will gladly open it up to any questions you guys might have.
Thank you so much, Haley, for providing your insight on pharmacist's role in helping patients who are in recovery. We did have one question pop through, so kind of jumping back earlier to talking about dopamine and the reward pathway. Is it possible to permanently damage dopamine receptors? And if so, what happens with permanent damage? And is it possible to fix this damage in the future?
Great question. So I don't think it's ever possible to permanently damage those receptors because, again, we're going to be kind of constantly in a cycle of rebuilding some of those enzymes at the base of our cells and pulling up more and more receptors, or up-regulating, down-regulating, just depending on what the brain needs. So if we're losing a lot of those dopamine receptors, the cell is still there. And then once our brain kind of recognizes that we're not getting so much extra dopamine from other sources, it's going to kind of relearn that it has to do that on its own. And so it's going to start building more dopamine receptors again. It's going to start learning that on its own, but that can take time. So I wouldn't say that it's ever permanent, but it can take some time for the brain to kind of kick back in and learn how to do that on its own again. So for example, what I counsel my patients on a lot is some depression. Expect that, normal things might not provide enjoyment for a little while, just because your dopamine receptors are learning how to find that enjoyment again. So going fishing, a good cheeseburger, those really basic, simple rewards that we used to enjoy are going to take some time to actually feel enjoyable again. And depending on the substance, on the patient, that could take several weeks up to a year. It just takes some time. What I should have done is show like a before, after substance use, and then a third brain of, hey, look, after a year, I swear it gets better. It does bounce back. I do a group with our veterans and I show them that picture exactly and remind them at the end that this isn't permanent. The good news is that you can bounce back to that original brain. It just might take some time.
Maddie shared she loved hearing your specific story and wanted to know exactly, or wants to do exactly what you had described as your job. And she's thinking about getting certified as an addictions counselor and getting that certificate, and wanted to know if you had done that, and do you think that would be helpful in your given role?
So my training background, I should have backed up. I did do a psych minor at Drake University. I do feel like it helped me quite a bit to understand kind of the diagnostic part and abnormal psychology before I got into this role, but by no means is that necessary or required. I know much less about what an addiction counseling degree would provide. Under my scope of practice, I'm not allowed to diagnose, and I am not allowed to provide therapy or psychotherapies. And if I did have a dual degree where I also had a different degree that allowed that, I'm not actually sure what the logistics are or limitations are. I don't think I'd be able to do them both simultaneously. So unfortunately, I don't know if that would be applicable in practice. Of course, if there's courses that you can take and learn and it's really exciting to you, do whatever you can to learn more and get engaged. But I don't think extra certifications are necessary or required for doing what I do, basically.
And bouncing off of that, we know that using patient-centered language is really important, but what's the best way to suggest patient-centered language regarding substance use disorders to other healthcare providers in a respectful manner?
I think it's always, you want to be careful about, not coming off the wrong way, or, especially when you're getting to know a new provider and kind of get a sense for their style. I always just very clearly, when I repeat something back to them, use the proper language and just kind of continue to reemphasize that. If you don't feel comfortable flat out, correcting them or saying something, just continuing to reinforce or make an emphasis on the wording that you use can kind of show them that, oh, that's the language I should be using. Even as I was preparing for this talk, I think someone had mentioned medication-assisted therapy, and I just kindly said back, actually, can we change that wording to medications for opioid use disorder or medications for substance use disorder? Because we don't like to use the term medication-assisted therapy anymore. And that's a person who had no idea, like, oh, I didn't realize that change. I'm so sorry. And they just really didn't know. So it's possible that those providers just aren't aware of what the impact can be and what those words are. We're constantly kind of changing them and tweaking to be the most respectful possible. So if you're worried, I just maybe wouldn't call them out particularly, but just make sure you're choosing your words wisely and emphasizing that.
Awesome. And then we do have some students on here who are going to be the new Operation Substance Use Disorder leaders. And they were wondering if you could share some insight on impactful events you recommend that they conduct at their local chapters.
Ooh, that is such a good question. Well, certainly you guys all probably know about APHA's Substance Use Summit, and that's not something you can host at your own site, but you can always do informational settings or do kind of mini kind of insights to maybe people who have gone to that before and kind of get a hint for that and drum up some interest in a bigger platform like that. I know on our site or at our campus, when we went to Drake University, we actually had a speaker come in who was a pharmacist in recovery, and he kind of just spoke about his experience and his what happened to him and how that kind of looked afterwards, the struggle of getting his license back, that kind of thing. I think personal stories are the most impactful when it comes to recognizing this. And certainly when it's a pharmacist, when it's someone that we hold to a high regard as it is as a fellow colleague, hearing them be vulnerable and go through this as well has been really impactful. That being said, it might be hard to kind of recruit that kind of thing or find that kind of speaker, but they're out there, they're willing to talk. One other thing that we did on campus is do like an opioid use summit. And then the following year, some colleagues after I left did an alcohol use summit. So just an educational event where we got to learn a little bit more. I did at our event share a little bit about my family's history with addiction and how it impacted me. So if you do have someone, again, that can share that personal story, that personal piece, I think it goes a long way to really speak to people and kind of get them roped in beyond just another educational thing when you're already, sick of classes after a whole long day. I'm trying to tie in that personal piece is really helpful.
And we just had another question come through. When we are taking histories from patients or first getting to know them, what are some ways that we can ask them about potential substance use disorders while still showing them respect and building rapport with them?
Yeah, that's a really good question. And we do have some standard questionnaires that kind of help us guide through those questions. So one thing I always like to say or remind people is these are kind of our standard questions. I ask everyone this. So it's not that I'm, asking you this particularly because I think you look like you're going to answer these questions a certain way. So usually once you get into the habit of, these are my standard intake questions and it's kind of a flow, sometimes throwing in substance use questions doesn't throw them off balance too much. It doesn't surprise them and they certainly don't feel disrespected because you kind of establish that it's part of the process. You have to ask about it. And you kind of take the onus off yourself and say, I'm supposed to ask these questions. If you want to dig a little bit deeper and still be respectful, I find it best to, there are specific screener questions that we can use. For example, there's one that I'm going to botch off the top of my head, but asking about prescription abuse or prescription misuse, there's a way to ask it in a way of, have you ever considered using more of your medications than prescribed? Or have you ever ran out of your medications early? So that's not asking, do you crush and snort your medications, but have you ever, ran out of them because maybe you're using too many or not as prescribed? So asking in a way that's more adherence kind of related and not making assumptions about how they could be overusing it or using it inappropriately. There's a specific kind of questionnaire that helps us word those. And again, it can be really nice to kind of pull out a questionnaire and say, hey, I'm supposed to answer or ask you these questions in a certain way. And finally, I just keep a straight face at all times because once patients start telling me things that are like, wow, okay, I don't let them see that. If I'm surprised by how much substances they're using and they're still standing, I don't let them see that. I try to keep as straight of a face, non-judgmental as possible and just say, okay, tell me more about that. Or when did that start? Or, just ask a few more clarifying questions without being like, wow, we need to talk about that, or making it seem like it's such a big deal that they're doing that. I normalize it. I make it sound like, okay, let's talk more about that, but it's not a huge deal. It's not a big deal. And then once I've gathered all of the information and I feel like they've been comfortable enough with sharing as much as is accurate and is truthful, then I'll kind of go into that. Okay, here's why I'm concerned. I eventually let them know that it's concerning me or, there's something that we need to talk about, but I wait until all of the information collection is done before I kind of let on to that.
Awesome. Well, thank you so much, Dr. Pals. Are there any other questions this evening? Well, not hearing any and not seeing any more come through the chat. Again, I want to thank you for joining us this evening, Dr. Pals, and providing so much insight on what you do and how we as student pharmacists can be empowered to help people who are in recovery or who want to pursue recovery. So again, thank you for your time this evening and thank you all for joining us.
Thank you guys.